Assalamu alaikum. My name is Dr. Sajid Hamid, and I'm a neurologist, and I'm doing fellowship in movement disorders, and I welcome you all. So today I will gonna present about chorea, dystonia, and restless leg syndrome. I have no disclaimers. So movement disorders. So we usually define movement disorders into either hyperkinetic, when the movements are increased as compared to a normal person, or hypokinetic, when movements are decreased, reduced as compared to normal person. You probably have already heard the lecture of Dr. Nadir Sayed Saab. He's a very experienced clinician. So he probably talked about Parkinson's disease, which have bradykinesia, rigidity, which are features of hypokinetic disorder. But at the same time, you people might have also talked about tremor, which is a kind of hyperkinetic disorder. So there are different types of hyperkinetic and hypokinetic disorders. And I will today gonna discuss about chorea, dystonia, and restless leg syndrome. So chorea. So chorea simply means dancing. It comes from a Greek word. Even the choreography shares the same root. So choreography, the way they organize the dancing in movies and on TV serials. So when we define chorea, being a neurologist or a fellow in movement disorders, we usually define different movements. So choreas are involuntary. So patients cannot stop it. They are hyperkinetic. Movements are too much. These are non-repetitive and non-rhythmic. Now, this is very much important. Now, when you noticed tremor, so tremor is rhythmic. So there is a rhythm, there is a to and fro movements, and it is repetitive. You find the same tremor happening. But in case of chorea, the movements are non-repetitive, not repetitive. So they all are different movements. They are not rhythmic. They are semi-purposeful. Now, by semi-purposeful, I mean since these are involuntary, so they might lift their arm or lift their shoulder, lift their hand, then they convert into some semi-purposeful movement. So the other person who sees them feels like, oh, they are doing it by their own. But in fact, they are not doing it by their own. They are converting the involuntary movement into something voluntary. Now, don't worry, I will show you the video. Hopefully, it will get cleared. And generally, these movements flow from one part to another part. Now, this is a video of chorea. Now, I will also define as we go on with the video. So, I'm playing it. So, you can see this is a middle-aged lady. I'm sorry. I'm doing it again. Now, you can see this is a middle-aged lady. Now, she will have some movements in whole body. It will be more in the upper extremities, in trunk, some in the leg, also in the face. Now you see, these movements are not repetitive, they are different. Check the hand movements, they are different. And did you notice this thing? I will just repeat it again. Now, she is moving this hand involuntary and then she touches her dupatta and tries to make it a semi-purposeful movement. See, again, the same thing. She's trying to touch his dupatta and feeling like she's moving by herself. So these are the semi-purposeful movements. You can see all these movements in the hand like are dancing. There is also some movements in the legs, some in the face. And these are not similar. All the movements are different. So these are non-repetitive and non-rhythmic. And she cannot stop it. These are involuntary. Now I will play it once again so that you people can appreciate it more. So you can see the movements, arms, legs, face, the trunk. All movements are different. These are the semi-purposeful movements she's doing. There is no rhythm to these movements. They flow from hand, going into the trunk, shoulders. They are in the legs. Again, she's doing the semi-purposeful thing. And she cannot sit still. You can see. she's not sitting quiet. She's continuously moving. And these patients have really hard time because these movements affect all of their activities of daily living. They can't eat properly, they can't walk, they have problems with their speech. Now, these patients have what we call a motor impersistence. By motor impersistence, we mean if we ask them to sustain a contraction, they won't be able to do. How it is? Let me define it more. If you ask a patient with chorea to keep their tongue out for like 10 seconds, they can't do it because they need to move. So they cannot keep their tongue out for like 10 seconds. If you ask them to grip my fingers, they cannot grip them for long. They have to move their arms. So this is what we call motor impersistence. They have to move. They can't sustain a contraction. This is what we do during our examination as well. Now, along with chorea, there are two other conditions, the athetosis and Bellism. They are similar to chorea in a way that they are non-repetitive, they are non-rhythmic, they are involuntary. The main difference is of the amplitude. If the amplitude, the movements are smaller, we usually call them athetosis. If the movements are very large, we call them Bellism or Bellismus. And in the intermediate, we call them chorea. And it is not uncommon that people with chorea will have some small movements as well. So we usually you will read terms like chorioathetoid movements. So there are chorea movements and there are some also smaller movements as athetoid movements. Now we will see another video. Now this is of the athetosis. Now just look at the right upper extremity as well as the right lower extremity. You can see fine movements. These are of the smaller amplitude as compared to chorea. Now, if you can see, there is some abnormal flexion of the index finger, also some hair in the thumb. Now, this is dystonia. We will discuss in later part of our presentation. So he has dystonia, but still he has some movements in his upper extremity, especially the hand. See, these are non-repetitive and these are of the smaller movements. And this, yeah, see, he cannot control it. These movements are growing by their own. But these are of smaller amplitude as compared to chorea. And his elbow is flexed as well. He cannot straighten his right elbow. Now, another video, this time of Bellismus. Now again, notice on the right side, the right upper extremity as well as the right lower extremity. See? Now these movements have higher amplitude. Arm, leg. So this lady has movements only on one side of the body. We call it hemibellismus. Hemi means half, hemibellismus. And one of the commonest or causes of hemibellismus is a stroke. So see, she's continuously moving her right side, arm as well as the leg, and these are of the high amplitude movements. And she's trying to hold it with her other hand, but still she cannot hold it. So again, these are non-repetitive, non-rhythmic, involuntary, and they flow from one part to another. Now, when we see these type of movements, the chorea, so then we discuss, okay, these are the movements, the chorea. So what is causing the chorea? So in adults, the most common cause of chorea is a Huntington disease. It is an inherited disease and we will discuss further about it. There are some other disorders that look similar to Huntington disease, but they have a different affected gene or different affected etiology. We call them Huntington's phenotypes. Then there are some acquired causes of chorea. It can be due to stroke, vascular, autoimmune, really like due to MS, metabolic, infectious, due to toxins, even drug-induced. Now the Huntington's disease. It is an inherited disease that is transmitted in autosomal dominant form. So usually these people have a positive family history and one of the parents is usually having this problem. Unless it is a newer form of mutation in the family. then you may not find a family history. And what happens? There is a expansion of trinucleotide, trinucleotide repeats, CAG, on chromosome number 4 involving a gene called HTT. The HTT gene encodes for a protein called Huntington protein. So in normal individuals, on this chromosome number 4 on HTT gene, we have these CAG repeats, but these repeats are less than 27. So this is a normal thing. If the repeats are more than 40, then it has a full penetrance. So this patient, if has more than 40 CAG repeats on this HTT gene on chromosome 4, even if a patient is like 5-year old, suppose, and we have this genetic testing and it is he or she has more than 40 repeats, we are sure that in future he or she will develop Huntington disease. If the repeats are less than 27, then he does not have Huntington disease. If the repeats are somewhere between 27, more than 27 and less than 40, then it can be intermediate. It, he or she may not have Huntington disease in future. We are not sure. We have to wait and see. If they have an Huntington disease, it is quite possible it's a milder disease, or it occurs very late in life, like when he's in 60s, 70s, or 80s. So as the number of repeats increase, so if someone has 50 as compared to someone who has 80 repeats of CHE, the one with 80 repeats will have more severe disease. One, two, they will have disease at a younger age. So the more repeats you have, the disease will be in a younger age and more severe. And it is also seen that as compared to parents, the offsprings, their children, will have higher repeats. So suppose a parent has 40, their son or daughter may have more than 40, like 42, 44, or 50. This is usually seen. It's not always the case, but this is usually the case. That's why offsprings usually have a more severe disease and an earlier age of onset as compared to the parents. Now, Huntington disease affects around 4 to 15 people out of 1 lakh in Europe. And usually it occurs in the adult population around 30 to 50 years of age. But we have seen cases even in childhood and when they are teenagers up till 70s. But usual age is middle-aged, 30 to 50 years. Now, unfortunately, Huntington disease has no cure. So there is no treatment that stops the progression of Huntington disease. There is no treatment to reverse it. So whatever treatments we have are symptomatic. We will discuss about these as well. So there is no cure. Once it is diagnosed, it will progress over time and it is a fatal. So death usually occurs 15 to 20 years after the initial symptoms. Now, if we talk about clinical features, so in Huntington disease, chorea is one of the clinical feature. It impacts, as I said, all the activities of daily living. Because of these continuous involuntary movements, they have difficulty eating, they have difficulty changing their clothes, they have difficulty showering, they have difficulty walking. Along with chorea, they may have dystonia, they may have some myoclonus. So it is possible and it is not unusual. It is a common thing that people with movement disorders have multiple types of movements at the same time. Like they have chorea as well as athetosis, as well as dystonia, as well as myoclonus. So it is possible. In advanced stages, bradykinesia may occur. So instead of more movements, they may become more rigid or more slower. But this is at extreme cases, in advanced cases. Now, along with these involuntary abnormal movements, these patients also have cognitive issues. So they have memory issues, they do not have insight what's happening around them. And they can be more aggressive. They have psychiatric symptoms, delusions, hallucinations. They can even have some violent behavior. And as I said, they do not have an insight usually. So they do not know what is happening with them. And the caregivers, unfortunately, who take care of these people with Huntington disease, they usually suffer the consequences because they try their best to help them, but the patient does not know what's wrong with them, and so it's difficult to take care of them. Now, how to diagnose Huntington disease? So usually diagnosis requires both symptoms as well as genetic testing. So you have these symptoms, these involuntary movements, some mood behavior issues, and maybe a positive family history. So you'll feel like, oh, seems like Huntington disease. Let's do a genetic testing. And if genetic testing shows CAG repeats more than normal, you're like, oh, this is Huntington disease. But there are some difficult ethical concerns as well, because suppose a patient has involuntary movements and you do the genetic testing, it came positive. Now, should we do the genetic testing of their children? They are not symptomatic at right now. So should we do or should we not do? If we do the genetic testing and if it comes positive, then if they are more than 40 CAG repeats, so we will say they will surely develop Huntington disease in future. So just think about it. If a 10-year-old or a 15-year-old knows that I have an abnormal Huntington gene and I will develop Huntington disease in future, so how will he survive? There will be no interest in studies, there will be no interest in sports, in marrying, having children, because he will only think about, oh, I will have this disease and I will gonna die. I will have these involuntary movements. I will be very much debilitative. So that's why it's very much difficult whether or not to do the genetic testing of the children. And usually it is not done in US until 18 years. So after 18 years, the children have to decide whether they want or not want. The parents cannot ask for genetic testing for their children if they are less than 18 years. This is how it goes in most of the states. As I said, regarding the treatment, there is no cure for Huntington disease, but we have to manage the symptoms. So for these abnormal movements, usually the medicines used are VMAT2 inhibitors that include tetrabenazine, deutetrabenazine, valbenazine. Now, these are very effective in controlling the movements. There are some issues. One issue is that it is not readily available in Pakistan. Even in US, it has very much insurance issues and cover. Two, that as I said, tetrabenazine, it may increase the depression and suicidality. So these patients already have mood symptoms, so you have to take care. They may further worsen the depression and they may even commit suicide. So this is a black box warning for tetrabenazine. If we can't give tetrabenazine, the second choice is antipsychotics, the dopamine receptor antagonists like risperidone, clonazepam, haloperidol. Usually the second generation are more used because of lesser side effects, like risperidone or quetiapine. Now again, the treatment is symptomatic, so other symptoms are treated again symptomatically. So since these people have difficulty walking, so physical therapy, PT is important, as well as occupational therapy. They may have issues with swallowing and speech. So speech language therapy is also important to help with their walking, their activities of daily living, their dysarthria, dysphagia. If they have psychiatric symptoms, they have to be managed accordingly. If they have antidepressant, we can use antidepressant if there are prominent issues of depression. If they are more aggressive hallucinations, then the dopamine antagonist can also help with these symptoms as well as controlling the movements. Now, this was briefly about Huntington disease. Now, as I said, there are also different disorders that look like Huntington, but they do not have the CAG trinucleotide repeat expansion. So these are often genetic as well. So what happens when we think somebody is having a Huntington disease-like picture, like these abnormal movements, mood symptoms, family history? We do the check for the Huntington disease gene. If it comes negative, then we check for other phenotypes. Now, one thing important I want to highlight here is that if someone, especially an adult person, has the clinical picture of Huntington disease and has a negative family history, The negative family history does not mean that he cannot have a Huntington disease. It is possible the parents may have genes somewhere between, say, in 30s, 35 genes. They do not have the symptoms. But the children now have more than 40 genes, so they may have the disease now. So if someone does not have a family history, does not mean it cannot be Huntington disease or you cannot get the genetic testing. You still go for the genetic testing because this is the most common cause of chorea in adults. Now, these are some of the causes of Huntington's-like diseases. There are some autosomal dominant disorders, some autosomal recessive, as well as X-linked. The autosomal recessive Wilson disease, I've highlighted it because this is one of the potential treatable conditions. So, in neurology, wherever we find some abnormal movements, whether it's a chorea, maybe generalized dystonia, we usually check for Wilson disease because it's a treatable and we do not want to miss it. Then there are some of the causes of the acquired chorea. If the symptoms are more on one side, then usually we ask for an MRI to look for vascular or structural causes. If they are occurring, again, more hemibalismus type movements on one side, it can be due to non-ketotic hyperglycemia. If it occurs during pregnancy, we can check for chorea gravidarum, even connective tissue disorders. And there are some other movements which seem like chorea, like tardive dyskinesia that occurs after dopamine antagonist use, or some dyskinesias, abnormal movements after using levodopa. This is more common in patients with Parkinson's disease who are taking levodopa. So these are some of the causes of acquired chorea. So we discussed a little bit about chorea. Now we will discuss about dystonia. So dystonia is also a hyperkinetic movement disorder. Dystonia can be slow or rapid. Now, as a neurologist or a movement disorder fellow, how to define dystonia? So dystonia are involuntary. One, these are muscle contractions too. Now, these patients have usually sustained muscle contractions that cause twisting or directional movements. So if someone has neck dystonia, so the neck muscles can contract and the patient can have their head moved in one direction. Their head can move towards the right or towards the left, towards the front or towards the back. If someone has dystonia in arm or in hand, their hand may twist. If someone have a dystonia in leg, their leg or foot may twist. I will show you the videos of the dystonia. So dystonia, because of dystonia, they may have repetitive movements, or if the dystonia is severe, they may have the sustained postures. So they may have a sustained head tilted or head directed to one side and they cannot straighten it. So these are the sustained postures. And these movements, the dystonia, are repetitive and they are the consistent pattern because these are the same type of muscles which contract every time. So suppose if someone has a focal dystonia involving biceps, so what biceps do? It flexes your elbow. So if someone has a dystonia at biceps, so whenever biceps contract involuntary, you will have an elbow flexion. So that's why these people have repetitive, consistent pattern of their movements. And sometimes dystonia may also appear as tremor. Now, in essential tremor, usually you have your hand tremor, and you may have a voice tremor, speech tremor, as well as head tremor. But usually in these patients, you will have hand tremor, and then these people usually develop the head tremor. But if someone has only head tremor, the neck and head tremor, but no tremor in their upper extremities, no tremor in their hands, then almost all of the times, this is due to cervical dystonia and not the essential tremor. We see these patients quite regularly when they have tremor in their head and they are being treated for essential tremor, although they never had a hand tremor, or if they have the hand tremor, but they have a history of head and neck tremor for like 30 years, and for the last 1 to 2 years, they might have developed an upper extremity tremor. So if someone has an isolated head and neck tremor, and or this tremor is present many years before the hand tremor, then usually the answer is cervical dystonia and not essential tremor. And these twisted movements occur because the agonist and antagonist muscles are contracting at the same time. Now, to give you an example, if I want my elbow to flex, my biceps will contract, but my triceps will relax. That's why my elbow can be flexed. Now, suppose my biceps is contracting as well as my triceps is contracting. Both are contracting at the same time. Then what will happen? My elbow can't be flexed. There will be a constant war between both of these muscles. And then there may be some twisting around the elbow, and then or there may be some tremor. So in dystonia, the agonist and antagonist muscles both are activated. Now, this is the video of the cervical dystonia. I will just play it, but before playing, you can see even in this still, this gentleman has a neck. Now this neck face is deviated. You can see this head is looking here on this side. This is his right side. So head is turned toward the right, but at the same time, you can see this ear, the left ear, is more closer to the left shoulder. So it's kind of complex posture. So his head is looking toward right. So the right head turning, but it's tilted towards the left. And the head is a little bit going back as well. So this is a kind of complex cervical dystonia. Now I will play the video and you can see these cervical dystonia. Oh, I'm sorry. I will play it again. Yeah. Now he's turning his head towards the right. Now I will just do it once more. Now you can see this is sternocleidomastoid. This seems quite contracted. That's why it's turning the head towards this side. You can also see sternocleidomastoid here, but this part is more contracted. Again, difficult. Even in neutral position, his head is like this, at an angle. You can also appreciate there is an asymmetry of the shoulders. The left shoulder is up as compared to the right. No, sorry, I will go back. No, he's walking. Now see again. One, the thing you can notice is that the left shoulder is up as compared to the right. The head is tilted towards the left and there is some turn into the right. See, he's coming back and you can see the left shoulder is elevated, head is tilted towards the left with some turn toward the right. So there are different types of cervical dystonia. If head is rotated to one side, we call it torticollis. If it is tilted, the ear is more closer to the shoulder, we call it laterocollis. If it moves back, we call it retrocollis. If it moves forward, we call it anterocollis. Now, in many people, it is possible that they have a combination of these movements. As in our video, last video, you saw his head was turning towards the right, so he had torticollis, but it was also tilting towards the left, so he also had some laterocollis, and head was a little bit going back, so he had some elements of retrocollis as well. So he had a complex cervical dystonia. Now, some other features of dystonia. So dystonia usually worsens with voluntary movements. Like when he was walking in the video, you notice there was more head tilted. And it varies with changes in posture. So this is a very important point. So dystonia varies. So when a patient is looking to the right, you may find it has more dystonia. If he's looking to the left, you may find it's less. So the dystonia varies depending on the posture. And usually patients complain that when they are more stressed or more fatigued, there's more dystonia as compared to when they are at rest. Now, the movement disorders characteristically disappear during sleep. When patients sleep, they do not have any movements. So if patient is having tremor, but when they sleep, there will be no tremor. If a patient is dystonia, when they sleep, they have no dystonia, except one condition, palatal myoclonus. So the palatal myoclonus can persist in sleep. Otherwise, all the movement disorders, they disappear, they stop when a patient is sleeping. So this is another important thing to be asked in the history. That and patient himself does not know whether he is having movements or not during sleep, but other family members will guide you that, oh, when he's sleeping, there are no movements. And these patients with dystonia have a sensory trait, which called gest antagonist. So what happens? These people have somewhat learned some traits that transiently, temporarily, for a short period of time, either stop or reduce the dystonia. So suppose if patient's head is tilted and a cervical dystonia, but they have some traits, the way the head may become straightened. Now I will show you the video of this as well, the gest antagonist. Now again, before I play the video, you can appreciate this patient's neck is going back. So it is more of retrocollis. Now I'm playing the video. Now see, his head is constantly going back repetitively. So he has prominent retrocollis. Oh, now see this. He placed his hand on his cheek, and now his movements kind of stopped. So these are kind of sensory traits. See, again, I'm repeating the video. He's having frequent retrocollis, and you can also notice this hypertrophied sternocleidomastoid. Now he just places his finger, oh, and the dystonia gets better. So when you evaluate for dystonia, you may ask this question too. Have you noticed anything that helps reducing dystonia? And many people will tell you that by placing the hand on their cheek, their chin, or even placing hand at their back or sleeping on a pillow or lying down on a pillow will help with the cervical dystonia. Now, this is how we diagnose dystonia. So we clinically we see at what age patient had dystonia, whether it was in infancy, childhood, early adulthood, late adulthood, which body parts are affected. Is it only present in neck? It is also present in neck as well as the face. Is it also present in the upper extremities, the lower extremities, torso? So it is focal, segmental, multifocal, generalized, or only on one side, hemidystonia. We talk about whether it's static or it's progressing. Is there any variability or not? There are some conditions where dystonia is present more in the evening as compared to the day. They have diurnal variations. I'm sorry. Then again, do we have any abnormal brain scan, whether condition is inherited or acquired? So that's why how we diagnose or characterize these dystonias. Usually, the most commonly in adult, we have focal dystonias and cervical dystonia is the most common type. We already saw two videos, but we also see blepharospasm, limb dystonias like writer's cramp. This is also called task-specific dystonia. So these patients with writer's cramp do not have any dystonia throughout the day. So when you see them eating, talking, no dystonia. But as soon as they start writing, their hand kind of and fingers kind of twist and they become dystonic. The same happens with musicians' dystonia. That they are fine, they can write, they can eat, they can play, they can do everything. But as soon as they start playing their musical instrument, the dystonia appears. This is kind of interesting that these are task specific. That's why it is necessary that when somebody comes to you in your clinic and they tell you that they have a task specific dystonia, that they have problems only when they write or only when they play some instrument, it is necessary you ask them to do that type of movement in the clinic. So if they have a writer's cramp or writer's dystonia, ask them to write. If they have any problems playing a musical instrument, ask them to bring this musical instrument and play in the clinic so that you can visualize the dystonia. Now, I will show you some videos of other focal dystonias. I will show you for blepharospasm. Now, in blepharospasm, what will happen? There will be contraction of both eyes. So patients kind of repetitively closes the eyes. In severe cases, they even cannot open the eyes. So you will see he's contracting the eyes. Now this is involuntary. This becomes more severe when there is more light, like in the daytime, when there is too much lights in the room. Now see, he's having constantly contractions. His eyes are closing. This is blepharospasm. Now, oromandibular dystonia. Now, this is an interesting video. It will also tell you the gest antagonist, the sensory trick this patient had. Now, I will play it, and I'm hoping you will hear the video sound as well.
A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q.
Now I will replay it. Now you have to look at two things. Number one, the speech, the sound, how it is. Two is face. You will feel there's some asymmetry in the face. Seems like his mouth is a little bit twisted. Just just pay more attention. I'm repeating it.
A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T, U, V. It gets worse as I...
Device that I used was this
now
straw.
He has learned a sensory trick.
So it wouldn't cut my mouth. I had to smooth off and put wax on the end.
Helps him. Now see this. Listen
A,
it.
B, C, D, E, F, G, H, I, J, K, L, M.
See, his voice start improved and there is a more symmetry in the face. So these are the sensory tricks that people have. Now this is a musician dystonia. Now pay notice to his left arm, left hand, that when he starts to play the music, you will notice there will be some dystonia in the fingers.
More or less
more difficult.
More difficult.
Can you see this finger? The third finger, it is kind of flexed. So when he's playing, this becomes flexed. This is a target session. It's only present when he's playing the piano. Now the focal dystonias are usually the idiopathic. We do not have any reason. But if it is generalized or multisegmental or hemidystonia, then usually they have an underlying cause. And generally, the generalized dystonia are of genetic variety or inherited. And they are usually named by DYT, like DYT1, DYT3, DYT11. Now there are more than 40 DYTs. And it is important to get an Z diagnosis for two reasons. Number one, even I would say three reasons. Number one, to name the diagnosis, because people have this condition, they have a generalized dystonia, and they do not know why they have. So by genetic testing, they can have the name, like I have dystonia type 1, type 2, type 3. 2, some dystonias are autosomal recessive, some are autosomal dominant. So you can have a counseling with them regarding their progression or the spread of this disease into their children. Third, there are some specific treatments for some of the dystonias. Like dystonia 5 is called Sagava disease, also known as DOPA-responsive dystonia. Now, as the name indicates, these are DOPA-responsive. They respond significantly to carbidopa, levodopa. The brand name is Sinemet. So you give them a low dose of Sinemet and dystonia just goes away. Then there's a DYT11. In these patients, there's dystonia as well as some myoclonus jerks, and they respond really well to zonisamide. So that's why it's also important to know the diagnosis to give the Z treatment in some cases. Now, as I said, if someone is focal dystonia, like dystonia only in the hand, dystonia only in the neck, dystonia in the eyes, blepharospasm, we usually do not need too much of investigations because these are idiopathic. But in cases of more generalized type of dystonias, we need to see the underlying cause. And we look for the comprehensive metabolic panel, the complete blood picture. There are some disorders like acanthocytosis, which is accompanied with dystonia. So you have to look at the blood smear. You have to see if it's creatine kinase, ceruloplasmin, and serum copper to look for Wilson disease, look for connective tissue disorders, and neuroimaging and genetic testing. So this is how we do workup for generalized dystonias. Now, how to treat dystonias? Now, in idiopathic dystonia, the best thing is botulinum toxin. So you inject the botulinum toxin in the involved muscles and they relax the muscles and the dystonia gets better. And this is, as I said, the common cause of isolated dystonias or focal dystonias. Now that Botox injections have to be repeated every 3 months. So they have these injections and they have to do it every 3 months, usually throughout their life. But in case of generalized dystonia, so if someone has dystonia in whole body, in their upper extremities, lower extremities, in their neck, then it is not reasonable to inject Botox everywhere. You can't do this. So that's why we can try some pharmacological agents, some anticholinergic drugs, baclofen, clonazepam, even VMAT2 inhibitors. But usually they are not that effective unless, as we discussed about some of the types which are responsive to treatment, like Sajava disease, the dopa-responsive dystonia. But otherwise, they are not much responsive. You can try these one by one. It's more of like an educated guess, a try and error, just to see which medicine helps. Then we also have some surgical therapies like intradectal baclofen to help with dystonia, some peripheral denervation, and some deep brain stimulation. Deep brain stimulation is also really helpful in patients with generalized dystonia, specifically generalized dystonia type 1. So this was a very brief overview about dystonia. Now the last one is a restless leg syndrome. Now what happens in restless leg syndrome? So in restless leg syndrome, there people complain of an uncomfortable sensation in their legs. And they feel an urge to move the legs. And it is only present when they are resting, when they are not moving, especially at night time. So people say, when I go to sleep at night, I feel some uncomfortable sensations in my legs, in my feet, so much that I cannot sleep. And I want to move, or I have to move my legs to feel better. So they get some relief when they move their legs or they get up and walk. But this relief is temporary. As again, when they come and lie still, they again have these unpleasant sensations and they are more at night. Now, when we talk about uncomfortable sensations, the patients describe them differently. Some people say they feel like pulling, like their muscles are pulling. They have like cramp-like feeling. Some people say they feel like an electric current. Some say itching. I feel like I have to move my legs to stop the itching. Some say dull pain, aching, it acts. There's some dull pain in my legs when I'm sleeping. Some say it's more throbbing pain. And typically, people say they feel like something is moving under their skin, like there is some bird, there is some insect that is moving in their legs. And when they move their legs, they feel better. Now, since this happens when they're more lying, and sometimes some people classify the restless leg syndrome as a sleep behavioral disorder. Now, restless leg syndrome can be primary, it can be idiopathic, and it can be secondary. Like it's common in pregnant ladies, and especially common in someone who have an iron deficiency and chronic renal insufficiency. That's why if you suspect anyone having a restless leg syndrome, you have to order these tests. You have to look for iron deficiency, you have to look for renal profile, and if it's a young lady, you should look for pregnancy as well. And if you find any of these problems, so if it's a pregnancy, you have to use a conservative management throughout the pregnancy, and afterwards it gets better by itself. If it's iron deficiency, you have to replenish the iron stores. Even if sometimes iron is normal, but at the lower normal limits. So it's better to give them iron supplements. Especially look for the ferritin levels. If patient is having renal insufficiency, then try to, if the cause is reversible, try to correct it. If it's irreversible, try to manage it by correcting the underlying abnormalities, metabolic abnormalities, like having recurrent dialysis, looking to correct metabolic abnormalities, and this help with the restless legs. Now, before going for the medicine treatment, it is always important to try the conservative measures. So we usually ask them to maintain a healthy sleep hygiene. So sleep hygiene means less caffeine, try to sleep at the same time, wake up at the same time, try massaging, exercise, not before the bedtime, because if you exercise before the bedtime, it will be difficult for people to sleep. So do some exercise, be physically active more during the daytime. Hot baths, hot baths help the people, as well as pneumatic pressure therapy. Some Estonians that give pressure to these legs. Some people find it very helpful. Now we usually ask them to try these measures first. If after trying this, they still feel like the restless legs are still affecting them and they're not able to sleep, then we go for the medical treatment. So we usually try gabapentin and pregabalin first. The reason being they have lesser side effects as compared to other medicines which are used and usually well tolerated. So usually the gabapentin or pregabalin is given at the night time before the bed. At this time, people usually have more symptoms. If this is not helpful, then we go for the dopamine agonists, the ropinirole or pramipexole. We can also use Sinemet for it. Now, the problems with these medicines, the ropinirole or pramipexole, is some of the side effects. One, these people with restless leg syndrome, they tend to become tolerant to the doses. So suppose if somebody is feeling well at 1 milligram of ropinirole, so say after a few months or a year, the same 1 milligram will not be effective. Then the dose has to be increased. Then if patient is taking gabapentin and dopamine agonists, if it is not helping, then a combination may be helpful. Try gabapentin or pregabalin along with a dopamine agonist and see how they are doing. If it's not helpful, then opioids. Opioids, as you know, they have more addictive potential, so it is not routinely used unless all the other treatments options have been used and exhausted. So this is about the restless leg syndrome, and this ends my presentation. And I'm really blessed to be worked at two of the very nicest and I would say great institutes, the Aga Khan in Pakistan as well as University of Virginia. And if you have any questions, I will be happy to answer if I'm online because there'll be some time differences. I will try to be online, and if not, my email address will be shared, and I will be happy if you could mail me the questions, and I will reply them as soon as I get time. Hopefully, I hope you have learned something new, and hopefully, you will love the next presentation too. Thank you very much.